Module 3, Pain and Inflammation. Here are your required readings, the major concepts that will be covered. Okay, so let's get started. This is chapter 11 from your Med-Surg textbook. All right, so pain. Pain is considered the most universal symptom. Many people complain of pain, and it is considered a significant public health problem. Pain disrupts lives and it can interfere with ADLs, activities of daily living. It costs a lot of money and many people suffer with pain. So if you work in the emergency room, 1 out of 3 patients that come in is going to say that the main reason why they're there is because of pain. And over half of all patients that go to their doctor's appointments, their primary care visit, will complain that they have some type of pain. So like I said before, it costs a lot of money, over $100 billion per year. So pain is a problem. When we talk about pain, it's important that you know what the definition of pain is. So back, 50, 60, 100 years ago, it was thought that pain reflexively followed a tissue injury. What that means is if you got hurt, some type of tissue injury, then you're going to have pain, and that's where pain came from. So we know now that that's not always the case. Pain perception is centered in the conscious brain, and pain represents the creative transformation of nerve impulses by the brain into a meaningful and emotion-filled perceptual experience, per your textbook. So what does that mean? It means that it's all perception and that no two people perceive the same pain the same. You can have 2 females giving birth and they will describe the pain differently. Maybe one has more tolerance, it didn't hurt that much, where the other one said, yes, it was excruciating, worst pain of their life. So pain is a perception by the brain. So now that we have a broader understanding of pain, now that all of this research has been done, there is some confusion about definitions and terminology around pain. So first question to consider, does all pain cause suffering? So what do you think? Does all pain cause suffering? If I say I'm in pain, if I'm at 2 out of 10 pain, the last 15 years, am I suffering? Then we have, is pain relief the same as having no pain? So what if you have a patient that is constantly in pain and you're able to give them some relief? Maybe their pain has decreased significantly, but they still have pain. Is that pain relief? Okay, or do you consider pain relief 0 pain? Another question to consider. How do health professionals develop a consistent pain language while acknowledging that pain is, quote, whatever the experiencing person says it is? So this means that pain is subjective. When you ask a patient, what is your pain level, or has your pain gotten worse? Has it gotten better? It's all subjective. We have to trust what the patient says, and we use that in order to develop our plan of care to see if what we're doing is working. So when we talk about consistent pain language, we are talking about pain scales, but again, it's all subjective because the patient, is going to perceive pain in an individual way. Then we have here noxious conditions in the tissues versus pain perception. So when you have a noxious condition in the tissues, that can be something physically harming the tissues. So maybe you have an infection, maybe you physically got hurt. Okay, we know those things will cause pain, but then we have pain perception. So this is just the patient's perception of the pain. So these are intertwined, and they affect the way that we treat patients. Moving on to classifying pain. So we have acute pain and we have chronic pain, and you should know the difference. So acute pain is usually when, you have something happen in the moment, some type of trauma. So there's sudden onset. It's also a shorter duration, so several hours to several weeks, usually described as a very intense, sharp pain. And usually when you ask the patient, where is your pain, they can point to the specific location. I have pain right here. When we give pain medications, it's usually very responsive, meaning that the pain will go away. and it's predictable as the tissue heals. So you can have acute pain because you have appendicitis. You can have acute pain because you bumped your elbow. And we know that that pain will get better over time as the tissue heals. So it's predictable. Then we have chronic pain. So this pain is going to be here for longer. So it's going to be 3 to 6 months. You can remember the 6 months part. That's easier. And there may not be an obvious link to tissue injury. So maybe there wasn't a trauma, maybe there wasn't a physical injury, there was no infection, there was no surgery that had a wound. There's no obvious link. This is described as achy, dull, stabbing, burning pain, and it's more diffuse. So if you ask the patient, where's your pain? They're going to say, oh, well, it's kind of in this area. It's kind of around here. It's not specific, so it's kind of diffuse. It's unpredictable and coarse. So as we would expect an acute pain for that pain to subside over time, chronic pain doesn't do that. It can come and go. It can stay constant. It can come once a month, once a year. So it's unpredictable. And it's resistant to many of the common pain management plan of cares that you would for acute pain. And there's no apparent biological purpose. So our body is a well-oiled machine, and pretty much everything in our body is built for a reason. There's a reason why we have it. So for pain, if you remember in our inflammatory response, pain is present to signal us, the human host, that something is wrong, and to go to that and stop it. So if you get hurt in your knee and you have pain, it's for us to draw attention to the knee so we can help to take care of it. But with chronic pain, there really is no purpose of that chronic pain to linger. In addition to classifying pain as acute or chronic, you can also classify pain by the point of origin. So by knowing which type of tissue the pain is originating from, that will give you a better idea on how to effectively treat that pain. So this table from your textbook 11.2 sums it all up pretty well. If you look on this left-hand column here, type of pain, we have cutaneous, somatic, and visceral. These three are nociceptive pain, meaning that nociceptive pain receptors pick up on the signals and send it to our spinal cord, to our brain, to get interpreted. So cutaneous, as the name implies, this is superficial skin and tissues, so usually you can easily locate where the pain is. Cutaneous pain, you can say it's right here, it hurts right here. It may be tender to the touch. Somatic pain is deeper than the skin. It's usually in the joints, muscles, bones, and it can be more difficult to localize. So you might not be able to pinpoint it, but you can say, oh, it kind of hurts, in this area. And that type of pain is usually described as dull, achy, sore, even stabbing. Then we have visceral. When you hear visceral, think organs. So you typically don't think of your organs having pain, but they could experience pain, but our body usually will interpret that as referred pain, which we'll talk about on the next slide. And that type of pain is cramping, dull, achy pressure. It could also be stabbing. Then the last one here is neuropathic. So neuropathic pain, neuro. So this has to do with our nerves, and our peripheral and central nervous system structures are affected. These can be difficult to localize, and it's usually at a point where nerve injury or damage has occurred, but that's not always the case, but usually there's some type of nerve damage. These are very unique, where you're going to feel the numbness, the tingling. You can have shooting, burning, pins and needles, and stabbing pain. So important that you remember neuropathic pain shows itself as numbness, tingling, pins and needles. All right, so moving on. So we're going to go over referred pain a little bit. I know we had this in fundamentals. So here you see a picture, color-coded picture of different sections and organs. So it's really interesting. So we have those nociceptors in our skin here, and we feel a lot of pain in our skin. We feel a lot of sensory input, right? We have touch, cold, heat, a breeze, wind. We feel all kinds of things in our skin. So those little feelers are always sending messages to our brain. Then we have our heart. Okay, this is just an example organ. And it can feel pain. If there's an infection or if there's ischemia, it is going to have, a degree of, quote, pain. So the messaging of these right here on these nerves, okay, so you see the skin, you see the heart, these are actually running right next to each other on the same path on the way to the spinal cord. When it goes up to the thalamus to our brain along that same line, the brain gets confused because it's so used to those skin receptors sending messages that when it gets a message from the heart, it kind of, doesn't take it as true. So instead, it takes it like if it's coming from the skin. So that is what referred pain is. So for example, if you're having some type of heart pain, okay, so let's look at the picture here. So you see this area, this is all potential, let me change the color, potential areas where you will feel this pain. So if you are having some left arm pain, then we may think that it's because your heart is in pain. Okay, it's referred. This is just the way that the brain is interpreting where the pain is coming from. So another example here, if you have left neck pain, okay, left neck pain, and of course this means that you haven't had an injury, you weren't working out at the gym and you strained a muscle. This is just kind of you're sitting there and then you start to feel some left neck pain or high shoulder pain. Because of these tracks being so close together, the brain is getting a little confused. The pain is actually could be coming from the lungs and diaphragm. Okay, so that's pretty interesting. Just remember, referred pain is usually from visceral pain from an organ. So when we think of chronic pain, remember this is dysfunctional pain processing. There's really no point to it. Our body doesn't gain any benefit from chronic pain, and our inflammatory response is out of whack. So when tissue becomes damaged or impaired, all of these cytokines, all of these chemical messengers get released, the inflammatory process begins, but something happens in that time and the nerves begin to reorganize and mixed messages start to come. So there is no purpose of it. So just remember, chronic pain is dysfunctional pain processing. Okay, moving on. So factors that shape the pain experience. So we know that everybody experiences pain differently, and a lot of the time and you can see all of the reasons here. So prior experience with pain. So say you've been to the dentist when you were a child and you had a horrible experience. Maybe they pulled out all your teeth. Maybe they pulled out one tooth and it hurt so much that you'll never forget it. So the next time you go to the dentist, you're already anxious. You don't want to go. You're already feeling the pain and they haven't done anything. So those previous experiences with pain will affect the way that you react to pain in the future. Same thing with expectations of pain. If you are going to get your blood drawn and somebody told you, oh, I went to get my blood drawn and it hurts so much, then when you go, you're expecting pain, you tense up, and you can actually cause pain that's not there. Your mind will kind of build that pain. Anxiety, same thing. This is all the same kind of mixed messages that you're giving yourself even before it's happened. Then we have sociocultural determinants of pain. Values and expectations. So in some cultures, it's frowned upon for you to express your pain. You're supposed to be very stoic, straight face, whether you're male or female or whatever. And then we have access to healthcare resources. So in some places, maybe other countries, or even in this country in some areas, if you don't have access to healthcare resources and you're in pain, you're going to find other ways to cope and deal with the pain. Language barriers, there can be a communication issue. Maybe the patient's in pain, but they can't communicate that to you. You as the nurse, understanding that these cultural differences exist, need to pick up on the cues so that you don't have patients that suffer in pain needlessly. So then we have gender. So according to your textbook, women have lower pain thresholds and have a lower tolerance for intense pain. That I'm curious to read about. Gender differences present after puberty, and men and women will respond differently to analgesia. So that is interesting. Keep that in mind. Genetics, again, there's many different factors that determine how you tolerate pain. And then older adults, very important that we understand, because remember, those baby boomers are getting older, so we need to know how to treat them effectively. And we have a slide coming up where we talk about this. All right, assessing pain and intensity. So this should be a review. I know you had a lot of practice on this. So there are lots of different pain scales, and they can be used on kids, adults, people who are nonverbal, or people who are unconscious. Every single person, every single condition, situation, there is a pain scale for that. So when you are assessing your patient and you're documenting, you should never leave the pain scale out. You should never document unable to assess or something like that. There's always a pain scale for it. So here are some common ones. We have our numeric rating scale, which is where you're going to say on a scale from 1 to 10, tell me what your pain is. Verbal rating scales, visual analog scales. So this one here is the little thermometer bulb. The higher you get is the more severity of pain. We have the focused pain assessment continued. So here has an O, O, P, Q, R, S, T, and 3 A's. They keep getting longer and longer. So onset of pain, quality of pain, region and radiation, severity of pain, time and duration, and aggravating, alleviating factors and associated clinical manifestations. So that's a lot of information. So important that you know what questions to ask to know this information. So the onset of pain, when did the pain start? Quality of pain, so describe the pain. Region and radiation, okay, where's the pain and does it radiate? Severity of pain on a scale from 1 to 10. Time and duration, when does this happen? How long does it last? And then aggravating, alleviating factors, so what makes it worse? What makes it better? We also want to do a physical exam, check range of motion, a neurological assessment, and motor function. You guys all practice this in health assessment, so you are aware. And again, this is to determine where's the pain, how limiting the pain is. And then you want to get a multidisciplinary team involved, especially if the patient's in the hospital. Use all the resources there that you can. We have physical therapists who can come and evaluate the patient and recommend exercises or other additional resources that they may need. Pharmacists, so that we can get some medication on board related to pain. And a social worker to help to see, once they're discharged, what kind of needs that they have. Okay. In assessing a patient's pain, the nurse asks the patient, what makes the pain worse? Which aspect of pain is the nurse determining? This is an aggravating factors. Okay, what makes the pain worse? What's making it worse? Aggravating. Okay, so I included this slide on purpose. These are the nursing diagnoses for pain. There's 2 slides, and I want you to realize, okay, remember, nursing diagnoses, all that is problems, patient problems. Look at all the patient problems that come out of just having pain. So ineffective respiratory function, risk for aspiration, risk for falls, ineffective health maintenance, risk for impaired renal function, constipation, risk for constipation, activity intolerance, impaired physical mobility. All of these things, all of these problems come just from the patient having pain. So go through each one of these nursing diagnoses and be able to answer why that is. For example, risk for impaired renal function due to pain. How are those two connected? Well, when you're in pain, you take medication, and sometimes if you're in pain around the clock, you could be taking that medication around the clock, and that can injure your kidneys. So we want to make sure that doesn't happen. So go through each one and make sure that you understand how pain relates to those problems. Okay, this is continued here. You see fatigue, insomnia, anxiety, disturbed body image, risk for loneliness, ineffective role performance. Again, this is affecting the patient's ADL's activities of daily life. So it's really important that we pay attention to this so that we can better manage the patient's pain. Now we're going to talk about pain management options. So we have our pharmacological, which means medication, non-opioid analgesics. We have NSAIDs, non-steroidal anti-inflammatory drugs. And you see the little umbrella here. That means that this is an umbrella term, meaning there's lots of NSAIDs that fall under this category. So NSAIDs vary in potency and elimination half-life. Okay, so what that means is not all NSAIDs are equal. They can be stronger than the other, and their half-life can also differ. So the amount of time that they stay in the body. So for these reasons, different NSAIDs are recommended for specific pain complaints. We're not going to give everybody the same type of NSAID. It is individualized. So here we have low potency NSAIDs with a short elimination life, such as ibuprofen. That's over the counter. You can get that at your local pharmacy. It's used for acute inflammatory pain and visceral pain. So menstrual cramps is considered visceral pain because we feel that uterus contracting. That's an organ. And then acute inflammatory pain, very generalized. That's why ibuprofen is so broadly used. If you injure yourself and you have some inflammation, if you have surgery and you have some inflammation, you're going to get ibuprofen. Then we move up to the high potency NSAIDs, still with the short elimination half-life, meaning it doesn't stay in the body that long, but they're higher potencies than the low. Example of that would be Toradol. And these are given for rheumatoid arthritis pain and acute gout. Then we have our intermediate to high potency that have a longer elimination half-life. So these are going to stay in the body the longest. And examples of this would be naproxen and meloxicam. Okay, these are given for migraine headaches, activity-induced muscle aches, and cancer pain. So cancer pain, it can actually get pretty intense. So these are high potency NSAIDs. And then I put the little kidneys here because you have to be really careful with renal function. When you look at this, if you see, okay, this, NSAIDs have a potential to put a lot of strain on the kidneys when used in high potency for long periods of time, then you're going to want to monitor renal function. So that is our BUN and our creatinine. So non-opioid analgesics are effective when combined with opioids. So that means you don't have to take as much opioid because you're kind of pairing it with an NSAID. And this potentiates the opioid effects, which means it makes it stronger. So some examples would be oxycodone and aspirin. We call that Percodan. Oxycodone and acetaminophen, we call that Percocet. Oxycodone, ibuprofen, Combunox. Okay, these are commonly prescribed for acute dental pain, orthopedic pain, or cancer pain. Then we have hydrocodone and acetaminophen. That is your Vicodin, Lortab, Norco, and our hydrocodone with ibuprofen, which is Vicoprofen. And these are generally used for acute and chronic pain. You're going to see these medications a lot in practice, and it's important to understand what it's doing to the body. When we give any medication, we have to make sure we know the side effects. So monitoring risks and benefits of non-opioid analgesics. This slide may make more sense once we talk about inflammation in the next module more in depth. So prostaglandin synthesis. Prostaglandins play a role in inflammation, and non-opioid analgesics will block, generally speaking, will block the prostaglandin synthesis. But prostaglandins also play a role in things that don't have to do with inflammation, such as our stomach lining. Okay, so if you are blocking that, then that stomach lining can become compromised, which is why when you take NSAIDs, there's a greater risk of GI ulcers and bleeding. It also compromises uterine wall integrity, which can cause issues in pregnancy, so you shouldn't be taking those in your third trimester of pregnancy. In addition, some non-opioid analgesics will inhibit platelet aggregation, such as aspirin, and that puts the patient at risk for bleeding and at risk for thrombocytopenia, which is low levels of platelets. So this you want to take into consideration. This is also teaching for your patients why we need to know what other type of medications they're on and what other health conditions they have before letting them start, taking these medications at home. The next type of non-opioid analgesic is corticosteroids. These are used as anti-inflammatory agents. And there's a list here of things that we commonly use them for, like arthritis, bone pain, lupus, sarcoidosis, inflammatory bowel disease, acute inflammation. So corticosteroids come in many different routes. So we have ointments, which is topical. We have aerosol, like an inhaler in the respiratory tract. We have drops, we have IV push, we have PO. So there's lots of different routes. What we have to remember is that our intended use is for its anti-inflammatory properties, but corticosteroids come with lots of secondary effects. One of those is improved appetite, which will lead to weight gain. It also can improve mood. High-dosed or long-term corticosteroids can cause hyperglycemia, myopathies, Cushing syndrome, and mental status changes. So this includes delirium and psychosis. So just remember, when you have a patient experiencing some type of acute delirium or acute confusion that's not their baseline, you want to do a head-to-toe assessment, and then you want to look at their medication list to see if there's anything there that could potentially be causing the behavioral changes. Okay, moving on to local anesthetics and topical rubifacients. So local anesthetics are medications that can be either topically applied or injected into nerves and tissue that will decrease or eliminate that pain sensation, but without making the patient lose consciousness, like if you were to put them to sleep under general anesthesia. So an example of that would be lidocaine. Here in this picture, dentists use that, injected into the gums so that we won't feel pain. The next one is topical rubifacients. These are applied topically. Example would be icy hot. It causes local vasodilation and also produces a cool sensation, which can be very smoothing, especially to muscle pain. Now we're going to briefly go over opioids. So opioids bind to our opioid receptors in the brain, and this type of medication also comes in many different routes. There are rectally given opioids, IV, subcutaneous, IM, PO, so lots of different routes. Opioids are used for severe to moderate pain. So what this means is that if a patient is reporting 2 out of 10 pain, we should not be giving this patient an opioid as the first drug of choice. So we want to make sure the patient takes the least amount of medication to have adequate pain management. Opioids are commonly used after surgery, so post-operative pain, and the gold standard for this is going to be morphine. So if you had surgery and you're having, moderate to severe pain, maybe your pain's a 6 out of 7 out of 10, or maybe you have some kind of acute condition going on like appendicitis and you go to the emergency room, most likely you're going to be offered morphine IV push. Okay, it's the gold standard when it comes to opioids. There is another option, Dilaudid. Dilaudid is much more potent than morphine, so keep that in mind. But that's also another common medication that's given for acute pain, moderate to severe pain. So with any other like with any other medication, we have to be careful with side effects, but very, very careful with opioids because they can cause respiratory depression. And if a patient's respiratory effort is not the greatest, or they're very drowsy and they're very sedated, and then you give them an opioid, this can make it worse. And we don't want them to not wake up. So when we give this medication, we want to check to see what their baseline is. And then after we give it, we want to check again to make sure that they don't slip into unconsciousness. So very important. Opioids also can cause nausea and vomiting. So since this is something that we anticipate, we already know that this can cause that, we can sometimes pre-medicate patients with an antiemetic such as Zofran before we give them the opioid. Opioids also cause constipation. So most patients, when they're in pain, they have decreased physical activity, so they're not moving around a lot, and decreased oral intake, so they're not really eating or drinking. So this in combination with the opioid that causes the GI tract to kind of slow down is a recipe for constipation, very, very common. So we're going to educate those patients, when they're prescribed this medication upon discharge, especially after a surgery. We want to make sure that they're aware, keep your fluids going, be as active as possible, increase your fiber. But even despite doing all of those things, they may still benefit from a stool softener or laxative. But that is definitely part of teaching for any type of pain medication, especially opioids. Opioids can also cause urinary retention, pruritus, which is itching, and when given to patients with chronic pain, it can sometimes, not all the time, but sometimes make their pain worse. Okay, so opioids are not always the answer for pain. We have to provide an individualized pain management plan for our patients. And really important, the goal should not be relief of all pain. Our goal is rarely to have the pain a 0 out of 10. We want the patient to have pain relief so that they can have functional engagement, so they can do the things they need to do. If we had a goal of 0 out of 10, it's unrealistic. Rarely would we get to that point realistically in the time frame that they're our patient, especially if they're in the hospital. Sometimes we have to explain this to the patient. So say you're meeting your patient for the first time and you're asking, what is your pain level? Do you have pain? And they said, well, my pain level is 5 out of 10. So you say, okay, where is it? You ask all of your PQRST questions, and then you're going to bring them pain medication. One other additional question that you should ask them is, what is their goal pain level? A lot of patients would quickly say, well, 0 out of 10, I don't want any pain. Well, let's be realistic. What pain level can I bring you down to so that you're a little more comfortable and you can function, versus being in severe pain. Okay, you get the idea. Okay, moving on. Then we have atypical analgesics. So atypical means not normal. They're not really considered analgesics. These are adjuvant therapy that sometimes combine with other pain medications, clonidine, antidepressants, some ion channel blockers. So these kind of work in combination and can lower pain, can be kind of like a side effect. So again, this is kind of trial and error. A lot of times these are used for patients that have chronic pain, because as you remember, chronic pain is difficult to manage, and sometimes we have to get creative with our medication regimen. So now I'm over here. So choosing a pain management treatment plan. So when a provider is choosing the best medication, they're going to consider the dose, the effective dose, route, and medication choice. You as the nurse, if you have a medication list and you have a patient in pain, sometimes you have several options you can choose from for pain management. Sometimes you have that icy hot kind of medication, that ointment. Sometimes it's going to be an ice pack or a cold pack that you have available, or you can give them a PO medication, a sub-Q. So you're going to have to make a choice. And how do you do that? Well, you want to make sure that the route is appropriate. So if you have a patient in severe pain, you may not want to give them a pill to swallow, because the pill is going to take much more time to be effective versus something where you're going to put intravenously, like an IV push morphine. So that's how you should be thinking. And overall, the ideal pain medication is going to provide the best pain relief. Okay, so if a patient has inflammation, we want to give an anti-inflammatory. And we want the fewest adverse effects. Remember what the difference is between side effects and adverse effects. Side effects are things that happen, but we can kind of deal with them. Adverse effects means it's going to interrupt something we probably have to change or stop that medication. And we want patients to see a pain specialist. Refer the patient to a pain specialist if their pain is not well controlled. especially if this patient has some kind of condition such as rheumatoid arthritis or lupus, where they're going to have this progressive pain for the rest of their lives. It's going to be difficult to manage and their quality of life is going to suffer. So get them the consult to a pain specialist. That is going to be a physician who specializes in pain management. They will be able to pair up some medications and trial and error and really give a more focused attention, more personalized, patient-centered care. Pain management guidelines. So there are some guidelines established by the World Health Organization, or WHO, WHO, and this is them. So pain medication should be given at regular intervals. If you have pain and you expect to have pain, say you just got out of a major surgery, and yes, we already know you're going to have pain, we have pain medication ordered. Well, we want you to take it as ordered. So if it's every 6 hours, we know you're going to be in pain, let's give it at regular intervals every 6 hours. Because say you don't give it at the 6th hour, you wait, you have a gap. Well, that pain is going to start to rise. And it's much more difficult to bring down an 8 out of a 10, a 9 out of a 10 versus a 5 out of 10. So we want to manage the pain before it gets so high. We want to administer the pain medication according to pain intensity. That's why your assessment beforehand is so important. That PQRST, how severe is your pain? How intense is your pain? That is going to determine which type of medication we give. We want to make sure that they know that the goal is to improve functional quality of life. We're not going to have unrealistic goals of taking their pain away completely. Individualized dosing, again, patient specific, situation specific. You want to pay attention to the dose and response. So if a patient is taking a large dose of an opioid, for example, and they're always lethargic, they're very drowsy, difficult to arouse, and they're sleeping most of the day, then we need to recognize that and suggest that the dose be lowered, because that is not an appropriate way to manage your care. You're over sedated, it's too much medication. And then we always have to evaluate the therapeutic response. When you see that word evaluation, that's the end of the nursing process, where we question everything we did to see if it worked, because if it doesn't work, we need to change something. So say, keep it really simple, you went, you did your ADPI, your A assessment. How much pain do you have? 8 out of 10 pain. Okay, what is the problem? You just had surgery. The plan is, well, I'm going to give pain medication and hopefully that will lower it. Implementation, you're giving the medication. Now we're going to evaluate. That's by going back to the patient and seeing if everything you did worked. You're going to ask the patient, what is your pain level? Well, my pain level is 2 out of 10. Perfect. The goal was 3 out of 10 and you're 2 out of 10. Everything worked. We're good to go. You're going to be doing that constantly throughout your shift. Now, what if the patient says, well, my pain was 8 out of 10 and it's only 7 out of 10. It just got, a little bit better. Well, we need to reevaluate. That's not very significant. That's still considered severe pain. So this isn't adequate. What can we do differently? Can we add in some type of non-pharmacological intervention, hot pack, cold pack, repositioning, exercises, something like that, maybe to help that, or maybe we need to let the provider know that there needs to be a change in medication or something like that. So that is what's the whole thing with these guidelines from the World Health Organization. And then this little chart here is from your textbook. It pretty much says we start low and then we go higher. If the pain is not severe, okay, if it's mild, then you're just going to give something that's appropriate, like an NSAID or like acetaminophen. If you have moderate pain, then you should be considering maybe a weak opioid or a medication that has that's adjuvant therapy. So, for example, gabapentin is usually used for neuropathic pain. But if you combine that with another type of medication, pain analgesia, then it may work in combination. And then, of course, for severe pain, you're going to want a strong opioid like that gold standard morphine, even fentanyl or Dilaudid. So the takeaway from this is we have a systematic approach. We have to assess and we have to reassess. Next are non-pharmacological interventions. So everything but giving the patient medication for pain. And here listed we have positioning. So there is not one best position that promotes pain relief or comfort. It really just depends on the situation. If the patient just had surgery and they have an incision somewhere, then that might limit your options for positioning. If the patient does not have any kind of limitations like that, then we're just going to figure out which way is best comforting for the patient. If you see in this picture, sometimes we don't know that the position that we are in is actually causing us, tense muscles, sprained muscles. So we can help position the patient so their body is aligned. We can take some pressure off joints, stuff like that, use pillows, wedges, stuff like that. But it's patient-centered. It's whatever the patient needs. Then we have heat and cold packs. So typically, generally speaking, you actually need a doctor's order for a heat and cold pack. In some facilities, they're there and you don't necessarily need one. So just keep in mind, we'll say facility specific. All right, so hot pack, we know that heat vasodilates. So you would never do heat for inflammation because remember, part of inflammation is going to be edema and swelling, and that's a lot of fluid. If you put heat on inflammation, it might make the edema worse because the vessels are going to open, more blood flow to the area. So heat will increase circulation and it has a soothing effect on muscles and bones. Cold is a vasoconstrictor, so we use cold for inflammation. The takeaway from this heat and cold is that you don't want to keep those hot or cold packs on for long periods of time because that can cause tissue damage, whether it's heat or cold. And we can actually alternate heat and cold on the same patient for relief. Okay, so heat would be for muscles, for pain, acute pain. Cold would be for inflammation, and that is generally speaking. Then we have range of motion and exercises. So there are some conditions, for example, we just talked about arthritis and osteoarthritis and rheumatoid arthritis. So range of motion and exercises for some conditions can help prevent or reduce joint stiffness. So we want to promote that if that condition fits that criteria. And it also prevents shortening of joint supporting ligaments. So when you are not moving for a while and your joints get really stiff, things start to change structurally. So providing that exercise range of motion can help decrease those changes, and then in turn you have decreased pain. So we want to, and here's a little light bulb here. Whenever a patient is going to have something painful happen, such as a physical therapy session, we want to pre-medicate them. So if you have a patient that has been experiencing pain and you've been giving pain medication throughout your shift, maybe like every 4 or 5 hours, and then you know that they're going to have physical therapy, then you're going to want to give them something before that. Because what can happen is breakthrough pain, okay? BTP, sometimes they call it breakthrough pain. So it's where your pain is managed with your current regimen, but then something changes, you do something extra. So in this case, they're having physical therapy, they're working their muscles, they're moving around more than they have been. That is going to cause their pain level to rise. So again, it's that concept of anticipating the pain so that they don't jump into a 10 out of 10, which is really hard to bring back down. So if we pre-medicate them, their pain will go up maybe a little bit or not at all. The patient will be able to participate in therapy, come back to room and bed and rest, and they'll be good to go. Continuing on with other non-pharmacological interventions, distraction therapies. So music, and again, music means whatever the patient wants to hear, whatever they feel is relaxing to them. Guided imagery, we described this in class where you use the own patient's imagination to kind of take them away to a different place. Hypnosis, that's kind of tricking the unconscious mind into changing their perception about pain. Does it work? I'm not sure. I've never been hypnotized. Prayer. I've mentioned prayer before. Prayer doesn't necessarily mean religion, but just spirituality. So that can help kind of put people at ease. It's comforting and kind of can bring them peace too. And if you're not anxious, then that leads to decreased levels of pain. Then we have invasive treatment options such as a TENS unit, that's a transcutaneous electrical nerve stimulation device. These are little pads that attach to the area that have pain, and they send little electrical impulses that will hopefully kind of distort the pain signal to the brain. Same idea with the deep brain stimulation. This one is a tad bit more invasive because you actually have electrodes, up the spine into the brain. But the same idea, we're trying to block those neural pathways. Managing pain in special populations. So we're talking about older adults and we're talking about adults with cognitive or communication impairments. So let's start with older adults. So pain in older adults go underdiagnosed, undertreated, which leads to ineffective pain management. So a lot of times pain is so common when we get older that it just turns into your normal. So if you've ever known somebody, or maybe you yourself is getting older, and when you're in your 30s, 40s, 50s, 60s, your body isn't quite the same as it was 10, 20 years ago. So say you're cleaning the house and then you sit down and you're like, oh, I'm going to feel this in the morning. My back's already achy. We kind of take that as the normal. So if somebody asks you, do you ever experience pain? Your answer would be no, because you wouldn't even consider that to be pain, right? So that can build up over time, and then all of a sudden you have chronic pain and you're just living with it. You don't even consider that pain, you just think it's your normal. So a lot of older patients are in that position. Also, older patients are likely to have more health conditions. So it is that older population that has the arthritis and the osteoarthritis and some other conditions that are progressive and cause chronic pain, which requires chronic pain management. But maybe they just don't voice it, they kind of just isolate themselves and they don't acknowledge that they have the pain. And also, it's not just the patient who's not acknowledging it, it's also us as the healthcare provider. The nurses, physicians sometimes kind of overlook the hints, the cues that the patient may be experiencing pain. So that is what this whole slide is about. So sometimes also physicians might be a little bit fearful that giving an older patient, some kind of pain medication can maybe have them, become dependent, addiction, or even over sedation, because as we know, older patients, their organs may not work as effectively, like their liver and their kidneys, so they have a tendency to become over sedated with, sedatives. So maybe if a patient is in a lot of pain, the doctor might be hesitant to prescribe a little stronger pain medication because of those side effects. So that's going to lead to a lot of patients suffering, needless suffering. So what we want to recognize is that older adults may manifest those signs and symptoms a little differently than what we would normally see in a non-older adult. So physiological changes that happen when you're in pain that we are familiar with. The heart rate might go up, the respiration might go up, blood pressure might go up, you might be diaphoretic, sweating, tense up. Those are all signs that the patient might be in pain, grimacing, those type of things. But in the older adult, they may not come off that way. So especially if the patient has chronic pain, because when you have chronic pain for the last 10 years, your body adapts to it and it's no longer going to have those same physiological symptoms. So you're not going to have the elevated heart rate, you're not going to have the elevated blood pressure. So if a patient came to the doctor's office and they said, I have this pain, I've had it for years, it's like, doesn't get better than a 5 out of 10. Yet you look at them and to you, they appear comfortable. They're sitting in the chair, their vital signs are normal for them. What this means is that you shouldn't think that they're lying to you. It's just that they have chronic pain and this is their new normal. They just deal with it. But that is no excuse. We still need to treat and manage their pain. So some older patients will exhibit behavioral changes, depression, anxiety. They'll have impaired mobility. So maybe they're not saying anything, but they're not doing as much as they used to do around their house. Their ADLs have been affected. So social isolation, maybe they're experiencing more falls. For example, at an assisted living, if you have a patient that has fallen 3 times this week when they really didn't have a history of falls, and you want to figure it out. So you're looking at the patient, do they have an infection? Let's see, what medications are they on? A question you might want to ask your patient is, do you have any pain anywhere? Is this pain causing you to limp or hold on to furniture as you walk around? That could be something that may be the cause of the falls in the first place. Sleep disturbance. So maybe the pain is keeping them awake at night and they're experiencing insomnia because they can't sleep. Reduce food and fluid intake. So maybe they're not in the mood to eat or drink, so they become dehydrated, malnourished. So these are some behaviors that you may observe, and before you think that it's something else, you may want to consider unmanaged pain as the culprit. And then we have adults with cognitive or communication impairments. Now this is the same realm, because we don't want to just ignore that they may have pain. Just because they can't verbalize it to you or express it to you in the same way that you would normally assess pain doesn't mean that the pain isn't there. So we want to be observant. We want to observe for changes that are outside of their baseline behavior. Next, we're briefly going to cover complementary and alternative medicine, also known as CAM, C-A-M. So the goals of CAM are actually the same goals that we have when we treat any patient: promotion of wellness, prevention of illness, reduction of side effects, improvement of the immune system, and enhanced quality of life. So this approach is different from what we're used to in Western medicine per se, but it still has the same goal. So if a patient chooses to do these things, we're going to support them as long as they're doing it safely. So classification of CAM. So we have 5 different categories. We have whole medicine systems, alternative medicine systems, mind-body therapies, manipulative and body-based therapies, energy healing therapies, and then we have dietary supplements, botanical and herbal medicine. So we're not going to spend too much time on these approaches individually, but this is just to give you an idea of what's out there and what a patient may come to you and say that they're participating in. So whole medical systems and alternative medical systems include ancient arts and practices, traditional Chinese medicine, naturopathy, and Native American medicine. The list is pretty much endless. All over the world, they're going to have different types of cultural related alternative methods to medical systems. So these are just a handful of examples. Then we have mind-body therapies. So this includes meditation, spirituality, prayer, yoga, imagery, tai chi, and zero balancing. So all of these things aim to put the mind at peace, to quiet the mind, relax the body, and that will, decrease pain. It will kind of create an environment for your body that allows for healing and relaxation. Manipulative and body-based practices, so massage therapy, chiropractic approaches, osteopathic medicine, and reflexology. All of these things have their benefits and their risks. So again, if patients would like to do this, they can go right ahead. We just want to make sure that it's not interfering with their safety, if it's not going to make a condition worse that they have or interfere with a medication that they're taking. Reflexology, this is just a picture of the soles of the feet, that you can see these little pictures, these little labeled areas here on the soles of the feet. When massaged skillfully, they can relieve tension and treat illness. So I don't know, I've never had that done myself. I can't attest to it, but some people do. So if it works for someone and it's not harmful, then we should encourage them to do what works for them. Then we have energy healing therapy. So again, this is something that uses energy to clear the mind of, or actually to set the stage for healing and well-being, to kind of restore your health using energy fields. Non-pharmacological approach, we welcome it. If the patient is into that, by all means, go right ahead. This slide lists some specific situations where you may not necessarily want to massage or manipulate a body, and a lot of these are just common sense. So you're not going to want to massage any areas of the body that's open, where there are open wounds, fractures, where there's a tumor, burns, a radiation site, all those kind of things. And if a patient is on blood thinners, then you wouldn't want to start manipulating their body, because there's going to be a high risk for bleeding. And then when you're pregnant, we also want to caution with massage, and especially from us also, we're not massage therapists, and for pregnancy you need a special certification to provide an appropriate pregnancy technique. And our last category here for the CAM approach are dietary supplements, herbal medicine, and botanicals. So this is going to include all of your over-the-counter dietary supplements, your herbal medicine, and of course your botanicals. So these are the herbal medicine and botanicals are from natural plant sources. It could be from flowers, seeds, fruits, those kind of things. There are more than 1,000 of medicinal herbal compounds, and each are different. So again, if a patient is taking these, we want to make sure that we know about it. So when you're reconciling their medication administration record, we want to make sure we're asking them specifically, are you taking prescription medication, and are you also taking anything that's not doctor prescribed, like supplements that you would get over the counter at your local pharmacy, or maybe you didn't get at a pharmacy, maybe you got it somewhere else. So that is included on their medication list. And sometimes those things can interfere with some other medications. So really important that we find out what they're taking. If they're not interfering with anything, then, you know, they're free to supplement however they'd like. And before we conclude this module, I just want to go over the main takeaways of pain. So remember, pain is subjective. We go by whatever the patient tells us their pain level is. If you have a patient that has an opioid dependency who's addicted to pain pills, everyone still deserves to have pain relief, to have pain management. So we do need to put our biases aside and trust that there is still a degree, a level of pain that we need to treat. Using pain scales, that is part of your assessment. You cannot treat pain without knowing that PQRST. So make sure that you understand assessment is vital when providing interventions for pain. Once we know what the pain is, what's causing it, we can hopefully figure out what type of pain, whether it's visceral, neuropathic, somatic, or cutaneous, because that can give us an idea of what kind of pain medication would work best. So we know that we have certain medications we give for inflammation and certain medications which are our go-to for acute pain. And we always want to start low and then high. So we want to start with non-pharmacological interventions if possible, right? The rest, the heat, the cold, the repositioning, exercise, range of motion, those type of things. And then we can incorporate some medications. We want to be aware of those side effects. We know there are very common some side effects of most medications for pain would be constipation. So remember that, nausea, vomiting, that's for opioids, etc. Teachings, we want to teach our patients about these side effects and how to take the meds to stay safe. And then we have to consider the older adults and how that differs on the way that we're going to approach pain. The different behaviors they might exhibit, or patients that aren't able to verbalize their pain so that we can treat them effectively. Okay, and that concludes this module.